minutes to grab their seats. I understand this is the third straight panel in a row, so we'll keep this interactive and we'll keep this exciting. We have an impressive lineup of panelists here, Sujay, Anjali, Alex, and Sheetal. I'll let them introduce themselves in just a minute, but they're doing incredible work, very fascinating individuals. And so it's a treat to be able to have them with us today. We also hope to have some roundtable audience participation, so all of you should stay tuned for that as well. Now, to kick off the panel, I'll introduce myself. I'm the chair of this session. My name is Shinjini Kundu. I'm currently a physician and medical researcher at the Johns Hopkins Hospital. So I'm doing my specialization in radiology, but before I went to medical school, I did all of my training in engineering. I have a bachelor's, master's, and PhD in engineering. And today my research focuses on artificial intelligence to try to mine information from medical images that humans can't detect for purposes of early disease detection and sort of better prognostication of disease. So the reason I became interested in this area is because medical data today is one of the fastest growing sources, and imaging represents a huge component of that. So can I see by a show of hands, how many of you have gotten either an X-ray or a CAT scan or an MRI or a mammogram? Can I see by a show of hands, please? So it seems that the majority of people in this room have been exposed to medical imaging, and medical images are one of the key ways that we either make diagnoses or confirm diagnoses in medicine today. And this is true across all fields of medicine. Now, in medicine, there's been a lot of development in treatments, but there's been less development in prevention of disease. And that was really the area that I became interested in. So in my research, we found that we were looking at osteoarthritis, which is a disease which is diagnosed at late stages today. Today, the diagnosis relies on development of pain symptoms and bone damage, but we were interested in seeing if we could detect osteoarthritis earlier than that. So we looked at cartilage images in the knee of people who are completely healthy, and we tried to see whether we could predict if a healthy person would develop osteoarthritis in 3 years down the line with high accuracy. So the interesting thing is that if you look at these cartilage images, there's nothing that really jumps out to the human eye. Doctors can't tell who is going to develop osteoarthritis just based on cartilage images of healthy people. But in my research, I developed a technique called transport-based morphometry, which uses artificial intelligence. And using this technique, we're able to find that not only is there a pattern there that is very sensitive for development of osteoarthritis 3 years down the line, but this is also a pattern that we can make visible through AI explainability. And we can actually use it to help doctors identify exactly where the defect is in the cartilage. We found that there was an area of weakening, and we're able to see that. And these are changes that are not perceptible to human eye, but areas where AI can help with early disease detection and to help personalize the sort of diagnostic process. So technology in general can offer a panoply of solutions in the healthcare sphere, from personalized medicine to spreading the benefits of medicine to indigent populations that may not have access to these resources, to even helping empower patients with their healthcare data. We're going to hear about some of these applications from our panelists. So I'm going to let them introduce themselves, and then we'll carry on with the discussion. So Sujay?
Yeah, hi. Thanks, Shinjini, for the introduction, and thank you, Ware, for inviting us over here. I'm Sujay Santra, founder and CEO at Ikure, which is a leading provider of primary healthcare backed by technology. Prior to starting Ikure, I was working in IBM Oracle for 12 years, last in Oracle as a solution architect. Ikure is in the process of setting up a chain of primary healthcare clinics that has doctors, medicines, all the tests being done. And then the whole thing is backed by technology. So our technology is spread across from the last mile, wherein we have frontline health workers who are selected from the village women and trained as community health workers. So they carry smartphone with our application and medic bags that is various essential point of care devices. So they go to the doorstep, captures all the data, and once they are able to capture, it's a hub and spoke model. So the hubs is like a physical space that has doctors, medicines, all the tests being done, computer eye checkup, and we have the mobile medical team which goes deeper into the pockets at our touch points or the spokes. So using a 3-layered architecture, we are able to provide a comprehensive primary healthcare which is backed by technology. So I'll tell a little more later. Thank you.
I'm Anjali Nayyar. I work for Global Health Strategies. As the name suggests, we're a global health consulting company, and our main focus is assessment and analysis of policy, helping governments, donors to develop strategies and ensure that technologies as well as products are available and accessible to people who need them the most. The New Delhi office is the regional office for Africa, for our programs in Africa and Southeast Asia. And I'll speak to some of the work that I do later.
Hi everyone, my name's Alex Emms. I'm the CTO of a company called Ever Medical Technologies. We've basically built a private blockchain network in Bangkok, Thailand, for government hospitals to transfer patient data amongst themselves. So our ultimate aim is to allow a patient to have complete control and access of their own health data, and to know who else has access to the same health data. Before I was working, obviously, in this medical technology company, I was working in BAE Systems in the UK as a cybersecurity consultant, so my background is cybersecurity. And whilst there, we were looking at how blockchain could be used in some government projects there. The problem we had in England is that they already had the infrastructure, so there wasn't really as much need to upgrade it to something where blockchain can be used as a tool. And so I ended up in Thailand because there was no existing infrastructure for the transfer of patient data. And so we're actually building that infrastructure, and we've got the government backing. So more than happy to answer questions after about technicalities about blockchain. But yeah, I look forward to talking a little bit more about the project today. Thank you.
Thank you. Great to be a part of such a nice panel, and thank you, RF, for the invitation. So I'm Sheetal Ranganathan, and by the day I'm a research consultant. I work with a global research and consulting firm called Evaluser, and I head the life sciences and healthcare operations, which puts me in a very interesting state, which also works with my curious nature, is to really be an observer. It's my job to observe and consult on disruptive trends in this area and help and advise private pharmaceutical or biotech companies as well as organizations in this space, which could either be healthcare providers or payers, to make them aware of what could change in the next 5 to 10 years and how should strategies be changing. On the personal side, I'm also a writer. That's mainly a hobby. I write on science and technology topics, especially on Indian science, and hopefully there will be a book out soon which would capture a lot of Indian scientists who have made groundbreaking discoveries, but as Indians, even we are not aware of them. So yeah, that's about me. I'm very excited to talk about AI and health tech today, because this is one of the disruptive trends that's going to change the game.
Thank you for those introductions. Like I said, these folks are very fascinating and are doing some incredible work. So the purpose of this panel is to explore the privacy and security issues that arise when technology transforms millions of users into data points in the healthcare domain. So let me provide some context before launching into some of the questions. In the engineering world, the components of security are threefold: confidentiality, integrity, and availability, otherwise known as CIA. So let me give you some examples. Today there are many diabetics who rely on insulin pumps. Now these are programmable devices with microcontrollers. Now that might seem like a boon, but it opens up new security questions because these devices are not password protected, they're not encrypted typically, or they haven't been traditionally. And you can imagine that it opens the door for hackers and people to program the devices who aren't doctors. And you can imagine the kind of risks that might pose to a patient. Same thing with pacemakers. The pacemaker regulates the heart's natural rhythm. But traditionally, these devices have not been encrypted. And so there have been several groups that exposed the risks that can occur when somebody other than a doctor who may not have the best intentions in mind hacks into these systems. So these are examples where what is compromised is integrity or how a device should function, as well as availability, which is, having a device function when you need it to function. So those are examples of new security risks that we now have to think about with medical devices that are arising. Let me give you another example. How many of you have a Fitbit? So Fitbit helps you track your calories and your steps, but it also can continuously transmit your biometric information. On your phones that have GPS, that's also a device that can transmit your location information. So these are kind of areas that we now have to think about, and we have to explore the new security and privacy issues that arise. So we talked about the medical devices, and we talked about the risks that happen with hacking. Now, the FDA in the US is saying that we need more security. So we need more passwords, we need more two-factor authentication, et cetera, et cetera. Now, my question for the panelists is the solution necessarily a technical solution, or is this going to be a regulatory solution? Or do we need a combination of both? So do we need to program in security into the devices and just hope they'll do their jobs? Or do we need governments and we need larger bodies to set down the rules for use? So I'll let anybody sort of take that question.
Okay, so maybe I can jump in. Well, the answer is yes. It's going to be both a technological as well as a regulatory solution. But I think the panel and the audience here can come to a conclusion if I just make 3 points. We can step back and see. The title of this panel, the discussion topic is the dawn of a new revolution in health tech. So what is health tech? So I'd like to make just 3 broad points, and then we could take the discussion forward. The first thing is that health, there is a huge value pool shift happening. So when all of us think of health, the stakeholders or the agents that come to our mind are patients, hospitals, medical colleges, diagnostic labs. Do you think of Google, Amazon, Apple, Microsoft? No, not the obvious stakeholders or agents when you talk about health. But if I were to give you just a simple statistic of how much these tech companies have spent in the last year on health, is exactly equivalent to what the global pharmaceutical and biotech companies have spent on R&D in health. That's about $30 billion. So this means that this entire space is up for a change. And soon you would be going to AI doctors, and that soon is not too far off, actually. It's a dawn, but we are actually in the middle of it already. And most of the solutions might just be coming from an Amazon or your Alexa or Google or Apple already. So that's point number 1. So by the way, you must have heard of Deep Blue, right? That's the one that had beaten Garry Kasparov in chess. The latest one is DeepMind. That's a Google tool. And it has just beaten MIT and Stanford scientists at elucidating the fastest protein molecule that could be a future drug for us. So that's where we are talking about health nowadays. So the second point I want to make is, Shinjini talked about personalized medicine because that is really the end point that everyone is trying to achieve by health tech. And when we think of personalized, there are three nuances to this word personalization. One is that medicine is going to get more precise. So you and I, if we are suffering from the same disease, at this point in time, traditional medicine, which is still modern medicine, by the way, there are certain clinical trials that are held at a population level, and a drug is prescribed for a certain condition, which, depending upon the severity or the stage of the condition, the dosage and the application form may differ. But what I'm talking about is really precision medicine at the genomic level. Each one of us have a very unique genomic, and if you want to complicate stuff further, it's not just our genes, but the genes of the microbiome or the bacteria that exist in us. So we are an ecosystem. So it's really doubling, or maybe making the scale go by 5x, because the number of bacteria that exist in our system is actually 5 to 6 times of the genome that we have on our own as our individual genome. So there is a lot of data that is being thrown out. So it's the world of personalized or precision medicine that we are entering into. The second nuance of personalization is how we experience health. So we spoke of Fitbit. We speak of apps. Many of us may have apps if we are, if you're managing, let's say, a chronic condition like diabetes, to simply monitor our dietary intake, or to manage our weight, or to order food from Zomato, which is an Indian app for ordering food, just like Uber. And food is what determines our health condition also. So or a Fitbit, which is really tracking our body characteristics in terms of the exercise that we do, or the steps that we take, etc., or the BP at certain point in time, or the pulse rate that we are maintaining at certain point in time. So these are experiences. And everybody wants in an ideal situation, a 24/7 app on the phone through which we could make our life convenient. We feel more empowered if we have access to a doctor or a health service or an advisor at the palm of our hand. The third nuance of personalization is personal rights, because there is so much data that is being thrown out because of this health tech revolution. And that's also one of the topics that we will delve into as a panel into greater detail. As to whose data is it? Is it my data? Is this the data of the lab or the organization that is putting in so much investment and money into collecting that data? Is my consent important? I'm the owner of this data, so should I be a privacy maximalist, that I would not part with my data unless I know everything about it? Or should I be a privacy balancer? I know if I part with my data, it's going to be good in devising new cures in the future, or helping study human evolution better or human systems better. So these are the debatable topics that we have to delve into and go deeper. And of course, there are regulatory and legal aspects of it, which we will look into.
Okay, thank you, Sheetal. One thing that kind of struck me is how much you compared this kind of health tech to consumer technologies like Uber and apps. So it really seems like health is becoming more of a consumer is becoming more of a consumer thing for patients. So you can order medicines just through an app. You can look up your symptoms on a symptom checker. And one thing that's interesting is that just as with other consumer technologies like Uber and Netflix that collect your personal preferences, and even Amazon, and try to learn what your preferences are and tailor their services towards you, there's also been concerns about whose data is it, and the balance between business interests and rights of people in terms of controlling how their data is used and where it is going. So I was wondering, Alex, if you could speak a little bit about that balance and kind of how you've experienced that in your work. And maybe Sujay can touch on this a little bit as well.
Yeah.
So the question is, how do you balance kind of these business interests from a consumer point of view with the personal rights of patients?
Yeah, no, it's a very good question. I mean, the fact is technology is moving at a quicker rate than any kind of government policies or regulations come in, right? So I just wanted to make that point, because the government regulations and policies, I mean, GDPR is only, two years old, so it's still pretty immature. It obviously laid down a very strict set of rules about how data should be handled and stored. But, you know, in Thailand, I mean, they're going to be following GDPR basically, but there is no regulation right now. And so from our point of view, when we were working with the hospitals, you know, and the government, and we're talking about how, you know, eventually we want patients to have access to their own data, not only access, but control, right? So control for their own data, both in the health data and also maybe any IoT devices that are connected, you know, to also have control of that. The problem is, especially in Thailand, is with the lack of regulation and the lack of rules that govern that, who drives that? And if we're going to do something, what stops the government just creating a new rule that basically just puts a roadblock to what we're trying to do? Now, our aim is pretty clear. Our aim is just to create a national, essentially a network of patient data where hospitals can transfer data between each other, and patients have all their data in one place. In healthcare, often you have a medical record in this hospital, a medical record in this hospital, a medical record in this hospital. There's no interoperability. Now, when we're talking about connecting all these dots, you know, connecting all these points so we have one record, but there's no regulation on where that's stored. You know, are these stored on government databases? Are they stored on our databases? You know, we kind of have to guess what the government's going to do. And if the government doesn't do something that we've guessed, then we're in trouble. So a lot of work has to be done between the technology companies and the government to help drive it together, I think. And so we've been lobbying the government in Thailand quite a lot about, because, you know, standards exist for storing health data and transferring health data, HL7, FHIR. And so we've been talking to the government, say, hey, look, like, these are really good open source ways of dealing with this. This is what you should follow. But the problem is there's not one solution fits all. There's still going to be some tailoring to meet their own, in this case, own government requirements or own government needs, to meet the current law, because, you know, a lot of these laws are outdated. So how do you know, like, you know, the way in which how do you navigate this world of storing data and the regulations behind it? And I think more has to be done from just the point that Sheetal was raising. More has to be done by the technology companies to work with the governments in order to help tailor these rules in such a way that it helps the patient. I think it's got to be patient-centric, but also allows the technology companies to maybe provide the services that they want to offer. And I think the line between the tech companies, and obviously I'm talking about tech companies, the tech companies benefits in the most, and the patient benefits in the most. You know, it's very murky waters. There's no clear idea of, you know, where that line sits. And I think that's extremely hard to navigate, and more work needs to be done.
So Alex, it sounds like you're talking about regulation at multiple levels. So there's, in your own work, you use blockchain to have a level of security. And then on top of that, you kind of talked about the need for self-regulation within a company, and then also regulation from governments, which might be a little bit more unpredictable, because it kind of takes the locus of control out of just the tech aspect of it. Now, Sujay, it's interesting because I think that kind of interfaces with your work, where you are using like machine learning technologies to try to assess risk and triage patients in maybe resource poor settings to try to increase access to health. Now, okay, you can imagine that that has multiple layers to it from the technological side, but also the response from the governments of the countries. So what has the response been from the governments of the countries where you've worked at, and sort of what have their attitudes and regulations been?
Yeah, so I'll take a little back. In terms of the problem with healthcare, we all know is healthcare unfortunately works in silos, meaning that when you are walking into the hospital, you pay for everything and the services. And if you want to take back your record for, let's say, any second opinion to other hospital, it's not so easy, at least for the common people. And that is the problem which we all people have faced. So here what's happening is the business takes over the patient's data privacy and the ownership of the data. So at Ikure, what we have done is we have built a collaborative ecosystem wherein we work with ground partners with several organizations, research partners with the governments, both at the state and the central levels. Like we are also working very closely as part of the Ayushman Bharat scheme, the model. And here what we understand is initially, I would say around 3 years back, government was not definitely taking us seriously. But now we are part of the Niti Aayog, the Universal Health Coverage, which is the government's own flagship program. And there what we see is that if you really want to think back on kind of balancing between the data privacy, the ownership, because see, what we have to understand is we really cannot stop technology anymore. I mean, that's unstoppable. And like, for example, the use of AI, triage, machine learning, that cannot happen without actually sharing of the data again. So that's the side. But on the other side, if you are not being ethical, so that's why, for example, apart from our primary healthcare clinics, we are working with IBM Watson on cardiac care. So let's say there's a chip, it's a Brevard patch, it transmits EKG, body movement, pulse, and the several vitals of the patient who could be like post-surgery of the heart surgery, they could be at their homes. And these patients' data is being captured onto the IBM cloud, and we are creating AI algorithm model and training the system to identify, let's say if you are monitoring 1,000 patients, how would be able to rank the patients based on their severity and the high risk factors. So again, when we are actually monitoring and balancing these things, how we would be able to identify, for example, in Meghalaya, we have started a digital clinic in partnership with government of Meghalaya. And there is a question of who owns the data, how the whole data practice and the ownership could be. We really do not have any problems that even the government is thinking ahead in terms of how they could come up with the DISHA, which is a data regulatory and ethical framework in line. So the government is also thinking very seriously on these matters. And we definitely have to think that data ethics and ethical things that, again, in case of AI, if I am not being ethical, I can really get to doing something unethical as well. But as a self-responsible organization, how do I ensure that what is ethical and what is not ethical? How do we create those boundaries? And how do we create those frameworks which could be accessed by anyone in terms of ethical framework? And that could be accessed by government, that could be accessed by private. Again, we have to also understand is that healthcare, let's say in India, only 30% of them is going to the government facilities. The rest, 70% is lying with the private. So if you're not able to bring the private also as part of this regulatory framework, you'll not be able to meet your mission and the objectives. So that's why I think we all, as the private public, has to come together and contribute to this ethical framework. These inputs has to be on a continuing basis so that it could evolve over a period of time. And that is how we would be able to achieve.
So Sujay, you mentioned the need for self-regulation, which I agree, it's a big component of it. But we also kind of saw the perils of what could happen when we just leave these companies to self-regulate. Like we've seen issues with Facebook, et cetera. So I think there also has to be a big component of patient empowerment and the need for the patients to understand what the risks and benefits are. So Anjali, I was wondering if you could tell us a little bit about that. And do you think that there is potential to increase almost a digital divide between maybe those who are educated and understand the value of their data and maybe others who have traditionally not participated in healthcare tech, who may not know the value necessarily of their data?
Thank you so much. And I've been listening, quite fascinated by the various points. And I just want to step back a little bit and give an example of TB to answer your question. I think when we look at personalized healthcare, we have to look at it even in a public health setting. And it's happening. Whether you're using drones to deliver medicine, as Rwanda is doing very successfully, it collects blood samples and it delivers medication. Madagascar has created an entire framework to address TB by doing tests and through drones and technology. You look at India, with 28 lakh cases of TB emerging every year, something needed to be done, and most of the cases were going to the private sector. So you had to set up a policy for the private sector to notify. Now, when the private sector notifies, you have to create a kind of a digital platform so that you can store that data and address. And the reason for private sector to notify was so that the government could provide free medication. This is long medication, and drugs can be expensive. As they started storing data, they created, the government created a Nikshay platform. The platform is doing actually quite well. Yes, there are initial hiccups, but they store data now. They're using it for tracking drugs. They're using it for tracking adherence. There are several others. For example, there's 99 dots that's developed, which is very personalized supervision using technology, where a packet of drugs is sent and they open it up, and then a message they have to call as they open the packet, and then SMS, and they kind of digitally connected to their provider. Other countries have also done the same thing. I think the problem here is digital literacy, really. There is a Digital Empowerment Foundation found that if you just take India, 90% of India's population is not digitally literate, does not understand what privacy and confidentiality mean, even beyond the Supreme Court judgment. And I'm really talking about all sections. We've seen breach of data by some of the stakeholders who had no business giving out medical records or sharing medical records. Then we've also seen in hospitals where there is no sensitivity. And particularly if you look at a public health setting where a breach of data or even lack of sensitivity or understanding of data immediately stigmatizes you when you have HIV or TB. Or even in some African countries, if for some reason your data gets the policymakers or some of the regulators to see that you're gay, it could even mean death. So it's really, really sensitive on how you handle data and how you make sure that the data is not just collected, but also those who are giving the data understand what the implications are. It's not just, so we need to have a very clear, unambiguous, informed consent framework before we share that data. And that, I'm sorry, just doesn't exist. It's not that people don't want to do it. I think they haven't got there. And even those who devise various frameworks don't really understand what digital literacy and informed consent or rights or even privacy and confidentiality mean. We've had significant challenges for HIV. We see challenges with TB. We are going to see challenges in other aspects unless we put the framework. So the technologies can be developed by private sector, but the government really has to keep a very clear framework there. The second point is that as you design the framework, we have a system across all countries where a group of people sit together and they want a perfect framework, which just cannot be implemented at the ground level. You either have no framework or you have a framework that makes it impossible for you to do anything. So I think somewhere we need to find a middle ground, and examples exist across the globe.
So Anjali, it seems like you kind of brought up a lot of examples specific to India with tuberculosis, and also kind of the fact that India has a huge rural population, which may not always be the case in a lot of countries. And this is a particularly vulnerable population to data protection. So Sheetal, I was actually wondering if you could kind of speak a little bit more about what are the unique kind of challenges to India when it comes to like health tech and data protection? Because we are, this conference is kind of geared towards kind of the Indian perspective.
Okay, so for once, India is not at a different level from the rest of the world is, as far as challenges that lie ahead of us. And why I say that is, because first is, all of us agree that there's just too much data that is being thrown out in the world. And that's exactly why we are discussing it, because that really puts rights in peril, right? And if I have to just give a very quickly a quantification so that you understand what is the amount of data. So, what comprises health? Obvious, everything that is let out of our tests or clinical care related information. What drugs are we taking? What prescriptions are we following? What diagnostic tests are we going through? And that forms just the tip of the iceberg, which is just 10% of data that a human being can bring along as far as health is concerned. The other one, which sounds esoteric for us at this point in time, but it actually isn't, is the genomics data that one human being could throw out, and that could add to another 25% or so. And the rest, 55%, is actually everything that determines health, which is the social determinants. And that's why I'm saying India is not too far behind, because the US and the Europe are struggling with the same situations, except that in US and Europe, they are a little step ahead of many nations, including India, is that they have already started digitizing their health data. So as a patient, I am more likely to have a health record which is digitized if I'm being treated in the US or in Europe than in India or all the other countries. And India is also, as we talk, making a digital health policy. It is, it is already out, the first draft, and people are reviewing it. So in 5 to 6 years, at least, the government is going to take massive steps in digitalizing health records. The challenges that lie ahead is, the biggest, but still the easiest, is to digitize. And Alex works in that area, so he's helping Thailand do that. I'm sure there will be many such setups which would be setting up in India. But the challenge around digitization is that how sure will we be as patients or as individuals that our data is protected? And of course, there are technologies available, and Alex can talk more about it. Blockchain claims to help in de-identifying patient data, and at the same time, being more secure. Because as I said, even if as a patient, if my health record is de-identified, just because of my behavior on what food I'm ordering or what medicines I'm ordering through my online pharmacy, or the claims data that might be sitting with my insurance company, there's just so many data sets that a hacker could easily re-identify. So that's the biggest challenge. After the digitization challenge, the next biggest challenge is how to make our health data secure. And, if we talk about US, which has a HIPAA compliance for over God knows how many years, So as a patient, my data is secured as long as it is sitting in my doctor's office or in my hospital that I'm dealing with, or with my health insurance company. But what about the other data? The data generated by Fitbit, or data generated by the weight loss app that I may have, or the data generated by the Apple Health app that I have on my iPhone. So the US is scrambling. They don't have a solution. All this data set, which is really 50% or more of my health data set, is sitting outside of the HIPAA regulation. So I think Europe will be a better example to follow. And I know there's a parallel session on GDPR that's on. It's just been a year since GDPR kicked in Europe. And it would be a great case study for all the other nations to follow, to see how to bring in workable and more holistic guidelines as far as data security, confidentiality is concerned. So these are the two big challenges that lie ahead.
Well, thank you, Sheetal, for that perspective. So it seems like there's a confluence of a lot of different trends that are happening. One is increasing digitization of the healthcare data. There's the consumerization of healthcare in general. Then there's health tech, which allows us to take measurements and sort of biometric data from patients at all times, and 24/7, even if one desires to look at that. Then there's also the kind of movement towards empowering people with their own data and protecting people from kind of consumer interest, business interests. And kind of we also heard about the importance of empowering people who may not kind of understand or may not necessarily be educated in the value of their data, and really encouraging them to almost take ownership. We heard about the need for regulation at multiple levels from a technological point of view. Now this panel, another piece of that is obviously cybersecurity, but I think that that's a little bit outside of the scope of this panel, although that is also another key component of that as well. We also kind of heard about the need for regulation at a government level as well. So it seems that there are a lot of different trends that are happening, and it's going to be interesting to kind of see what comes out and what direction things go. I just wanted to ask the panelists if there could be one sort of takeaway or one area for the audience members here to keep in mind as they move forward and go on with sort of their lives after this conference. What would it be? And after that, we're going to open it up to questions. So I know that a lot of you have a lot to say. So.
I mean, I really think that one big takeaway is, just be aware of what you're sharing and be aware of your rights. The right to ask for your medical records, the right not to share certain information despite being probed and despite insistence. So I think, to me, that's really, really important. And to me, it's, we're sitting in this room, all of us are more privileged. But even as we go out, in a lot of work that we do at the field level, we always do guide the communities about what they should share and what they should be aware of.
Yeah, in our case, so for example, our clinics are in the rural, semi-urban and the urban locations. We have treated close to more than 1 million patients, and any intervention which we do has always been through the community mobilization and telling that, okay, these are the benefits and this could be the advantages and the disadvantages of the various data sharing protocol on a higher level. I think patients, the stakeholders, the practitioners and the providers all has to have that trust factor within to understand that yes, this data is good for me for the future of technology, future of medical science, but we also have to understand that what could be the downside of being unethical or something like that. So for us, we have to be completely aware of those facts.
Yeah, I'll just add on to those two very good points. I think in Thailand right now, if you ask the patients in the hospitals that we're working with, do you think it's important to have control of your own health data and know who's accessed it? I think in general, they'd probably say no, which kind of makes my company basically pointless. But I just know that I know that in the future, there's going to be a change, right? There's definitely going to, we're already seeing it. As these scandals happen, like the Cambridge Analytica scandal, now I think most people with their data on Facebook understand the importance of what data they put on Facebook and what data, maybe what data they don't share with their friends. And I think as people become more aware in the West anyway, I think it's the natural transition is the wave comes over to the East. And so I think maybe now they won't understand the importance of what we're doing, but hopefully in 5 years they will understand and we'll already be there with a solution. And so that's why we're doing what we're doing. Otherwise, I don't know why we'd be doing it. Yeah. So I think linked to that is, and just a little change about the electronic health record. So I have my electronic health record, which is split into all these different parts. When I transfer my medical record from one hospital to another, in Thailand, they'd print out the whole physical copy, and I'd take the physical copy to this other hospital. Obviously, extremely bureaucratic approach, very time-consuming and costly. Now, we're going to automate that, but then we're also going to help by modularizing parts of the EHR, parts of the electronic health record, because if I'm going for a regular checkup about my knee or something in one hospital, why do they have all the information about my sexually transmitted diseases, which I don't have, by the way? But yeah, why do they have all this extremely sensitive data when really they only need certain parts of the information? They need my allergies, maybe some of my vitals. They don't need the whole record. And so we also want to make sure that that's also applied across Thailand. And then as a patient, they can see what hospitals have what parts of my health data. And I think that's quite important. And I really think that people, in the 5-year, 10-year future will start understanding the importance of who has access to what data and being able to control that. Yeah.
All of that, that all of you spoke, and one more. We've talked about challenges and basically talked about things that should scare us. But the future is not that Orwellian as we have sounded. Having a lot of health data in the end is extremely good, because this is only going to lead us to better clinical outcomes, better cures. And Shinjini is doing, exactly that. Fantastic work if you get to speak with her. Because of her research, patients can now determine osteoporosis probably 3 to 4 years ahead of the time when the disease would set in. So having more health data is certainly good for humanity. As soon as we are able to, work out solutions to these teething challenges, which is data security and data confidentiality, and many people are trying to work on it, the future is bright for human health.
And on that note, we will transition to the question part. So we'd like to hear from you. As I mentioned, this is an interactive session. So I see there's a gentleman with his hands up. I don't know your name, but do you mind introducing yourself and your question?
Just press once.
Okay, thank you. Thank you for the wonderful session. My name is Vinayak. Based on my experience on applying technology to healthcare, a few questions and maybe thoughts. So we're talking about this sort of disruptive technology that's come into healthcare, and humans will get replaced and all of that. What I find sometimes that's a little bit of hype, because this is not the first technology wave healthcare has seen. Imagine before the automobile was there was no ambulance. We're talking about the drone now. Yeah, of course, that does a phenomenal job with Zipline in Rwanda, but imagine there was no automobile, what happened to healthcare then? Or in the domain of radiology, before digitization, you had these films, massive amounts of films which had to be recorded. There was no digital CT and MRI. So all I'm saying is that this happens probably every 20, 30 years, that sort of new trends in technology come in and multiple sectors get impacted, including healthcare. So that's just maybe food for thought. Talking about AI and machine learning specifically, where a lot of people tend to say doctors will get replaced. Again, my experience, I think that's a bit of hype, because the human in the loop, no matter, unless, of course, we get to a super AI, which I don't see coming anytime soon, the human in the loop will always remain. What is machine learning today? It's statistics on steroids. Anybody who's done machine learning, has done OpenCV, TensorFlow, and all of that will understand that. It's statistics on steroids, massively powerful, massively impactful. But can you replace a doctor? I don't think so. Can you aid the doctor? Absolutely, yes. Again, food for thought. Third, on privacy, I'm for that. I'm very, very paranoid now after Cambridge Analytica and all what Facebook does not do. But I'm also seeing the generation maybe younger to me may not care, and maybe what we're getting into is a new definition of privacy. Maybe we're getting to younger people saying, I'm okay to wear Fitbit, give my data to somebody, I'll wear it for 2 months, pay me $2,000. I'll wear Fitbit, upload something to the cloud as long as you're paying me $2,000. I'm just making these numbers up, by the way. Point being that there will be maybe data exchanges and people will have a new definition of privacy, at least the next generation. That's just, again, what I'm seeing anecdotally with not my generation, but the generation younger to me. And on Alex's wonderful work with blockchain in Thailand, that's really fascinating because, and I'll maybe talk to you offline, why you chose blockchain and not a private cloud, and also how do you create a business model of incentivizing at least private hospitals to collaborate with each other to effectively create a Dropbox for EHR. But that I can talk to you offline about. Thank you.
So it seems like the questions kind of get at the dynamic nature of these problems. So first one is kind of innovating for the future, not just for the current sort of problems that we have, but kind of anticipating where things are going. Is that seems to be one of the kind of points. The other one is the dynamic nature of privacy, because the sense of privacy that maybe a millennial has is not the same sense of privacy that somebody much older has, and that is something that's generational and something that it's also going to change over time. And then the third point is about, we've talked a bit about health tech, but then a future, a big component of health is the doctor, right? So where does the tech part fit in to the existing way that medicine is practiced? So it seems like Alex has some thoughts on that.
Yeah, I'll start us off. Yeah, very good questions, and we'll talk after, no problem. So I wanted to say, about the AI replacing doctors. Like you pointed out yourself, I think definitely is. Sorry.
That's not happening.
Yeah, it's not. Yeah, it's not going to happen. Yeah, but not anytime soon, anyway. Because actually, not only is it the technology is not there. Even if it was, I don't think the society, would accept that yet, right? But I think aiding is definitely, like you said. Think about this: if you're in rural India and you could speak to a doctor, one of the top doctors in America, let's say, right? You'd probably do it, from a telemedicine point of view, if you could, have a phone call. Now, what if you could have a teleconference call with your local doctor, but he's being assisted by all this, machine learning for prescriptions that these American doctors gave? I think that's probably naturally the first step, right? Where, and then eventually you're getting these local doctors that are getting better training because of this AI that's been done in America, let's say. So 100% agree with you there. Now about the data exchange, right? Millennials, saying, it's fine, look, Fitbit want my data, but that's no problem. And I actually do agree, right? For that type of data, they might not be too worried. But then you were saying, having a data exchange where you can sell your data, but you still need those regulations or policies in place to actually say that is your data, rather than Fitbit just saying, oh no, it's our data. You were wearing our Fitbit. It's our data. You have no leverage. You can't sell anything because it was never your data. So I think there still needs to be some policies, policies and regulations in place to say that it's your data. If you want to sell it to Fitbit, that's fine. But right now, it doesn't work like that, right? Yeah. And then about the blockchain side, just a quick point. By no means are we saying that blockchain is the solution to the problem of interoperability between hospitals. We're just using it as a tool because it offers, let's say, the advantages that you'd want in an interoperable health platform. Blockchain naturally offers those, the advantages of trust, transparency, and data security. But again, we can go into that further after. Yeah.
And I can also kind of speak to the role of maybe health tech, in the practice of medicine. So right now in medicine, the amount of medical knowledge we have doubles every 2 to 3 years. And in order for a doctor to keep up with all of the medical advances that are happening, he or she would have to read 26 hours a day. Now, if anyone can find time for that in a day, let me know. But we see an incredible explosion of medical knowledge and information. And so when we talk about AI, it's not necessarily to replicate what humans can do, although that is a lot of the focus of a lot of companies today. But it really is how to help the doctor become a better doctor in light of all of this information overload. And at the end of the day, we must realize that AI is a tool. It's like a calculator. The calculator didn't replace the field of mathematics. It just changed it to make it maybe more interesting. And I think that at the end of the day, when AI comes into medicine, the effect will be similar, that it'll make medicine more interesting, both for doctors and for the patients as well.
And I think here all technology is really an aid to equitable access. Drones should be here reaching out to tribal areas where no health worker can go or maybe has gone. And secondly, about the millennials, I think for me the big thing is informed consent. If you know what you're sharing and if you know what's going to happen and you do it with that knowledge, absolutely fine, it's your choice.
Yeah, one final comment. I think for India, it's extremely important because at the end of the day, we've said enough, AI is never going to replace a doctor. But access, affordability, India has 5 lakh doctors less than what should be. If with AI and ML and with computer vision and with virtual health, we can solve our access problem. And in any case, affordability will become a huge benefit of it, as it is true for all technology. A human genome in 2006, if I were to go and get it mapped, would cost me $14 million. I can get this done as a service for $1,000 now. So affordability and access are the biggest, advantages that this would enable.
I can see that there are some more questions. So those questions, can you raise your hands up a little higher? So in interest of time, why don't we stack some of the questions and then we'll have the panelists kind of respond to them. So sir?
Yeah, I'm Yadagiri from Hyderabad. So one thing here in the medical record data management, state is doing a lot of good thing in certain areas. Look after that, peculiarly ICDS scheme. A child of a neonatal child somewhere in the womb of mother, they started to have 2 workers in the village, A&M Asha and Anganwadi volunteer. So they are making a lot of record of that pregnant woman till deliver and post the child has to become. But this data is been not giving that in the public platform. Only they are monopolizing it. And certain period of time they are completely dismantling this. Come to the 4th year, 5th year of the child, it won't get anything from there. And this has to be maintained a record. And that's next one, birth and death record. Anyway, the state is making to be collect this all the data of birth and everything. Whatever the health problems of all the problems are there, insidely can maintain a data like that also. That might be useful. Ultimately, state is a sovereign to make it the data. Tomorrow, X hospital, Y hospital may give, it may be a questionable or contestable. But if state can do that, already doing in certain areas, why don't it can be like, in a way, like a blockchain at district level of health record, not to the entire. If that comes, it makes a lot of impact on the health revolution, even in the downtrodden level. That's my view.
Thank you. Yes, sir.
Hello, I am PK Sharma. Actually, just I want to have some simple questions from the maybe any panelist, what you deem fit. We generally, when we take a tests or like cholesterol or like that, so we generally find there are variation in the references of various types of records. And why is it so? So it should be standardized. Say, for example, diabetes less than 100, or so some may range in a high level also. So no doubt we consider this medical record as a customer property. So this whether these protocols which madam is telling about this of digital health policy, the protocol which is coming in that policy, or it is internationally accepted or it is country accepted, what is the degree of I mean acceptance of echelon, I mean this protocols. And secondly, still we find in our TV or in our social media, there is not much ambulance facility available for the remote persons. What I think Ms. Sujay is telling regarding some reference to this point. So still we find that people are carrying their ladies or like on a stretcher rather. So, and also I am very, we are people which are having a enormous wealth, they are going abroad for the critical, I mean the illness like cancer. Still we are not having, though we have an institute here in India. So we have to endorse something in that health policy while having in the draft stage or whatever stage it is. So these are the few points I noticed from my experience, which I want to have some views on of the panel.
Thank you for that question. We'll get one or two more questions stacked, and then we'll get the panelists to respond. So keep your hands up if you have a question. How about we take a question from that side to kind of balance things out? So yes, you.
Hi. So there was a little bit of discussion about informed consent, which is what I wanted to talk about. So maybe this question is directed at you, Anjali, although obviously you guys can jump in as well. So I think recently, sort of the notion of informed consent being the metric by which someone sort of allows their information to be taken has come into a little bit of, as it has been discussed at least, because there are some limits that we can obviously see, and especially I think in a field like medicine, where you have certain higher stakes, it might be more difficult to make those kind of choices, especially in a system like ours, where you have your public health delivery system tied into a framework like Aadhaar. And this even actually, I think, speaks to what you were talking about, millennials, which I recently read an article where I think New York Times had done a survey of like millennials and lower, which basically said that it wasn't that they didn't care about their privacy, it's just that there were certain services, including social networking services, they felt they had to use in order to actually fully participate in like their lives. And so what they intend, instead of like, so what they planned or how they thought about it was basically just to flood all these social networks with a lot of information, and so kind of just like drown vital information out by noise. And so my question is basically, in this situation where you don't necessarily always have an option of whether or not to provide consent for something, if any of you have thought about whether informed consent is a model that works, or if maybe there are certain alternatives that you've come across or anything of the sort. Thanks.
All right, how about we get the panelists to respond to those questions, and we'll take the next set.
Yeah, I think in case of, let's say, if I take about the informed consent, so the way that could work, you see, on a day-to-day transaction level, so for example, when we are issuing the digital health cards and there's a form, and then we explain it to the patients that, you know, the data would be kept secured. However, we also have an IEC, Institutional Ethics Committee, in place, which has different top-notch surgeons from the government hospitals, as well as the chairman from the Drug Control Authority of India, wherein, let's say for the research purpose, if we are working with University of Michigan, McGill, MIT, so there is an IRB also in place, Institutional Review Board, and they decide that which of the data has to be patient anonymized, how this could be ethically shared, and things like that. And whatever it is done, if we are not breaching about the patient's privacy, that has to be ensured. So this is on the transactional level, we have to understand that to what extent those transactions with the knowledge of the patients, maybe on a day-to-day basis it's quite difficult, but on an overall basis they know that, okay, my data is there, which is safe and secure. So that is, I think, one of the ways to look at it.
I think Sujay said it, so do you still want me to respond to this? I think he's, yeah. Except that, informed consent cannot be outside of any framework. There has to be a legal framework or an ethical framework, and within that, informed consent needs to be done depending on the population group. There have been videos for informed consent as well to explain what they're really consenting to.
Okay, we'll take the next set of questions. So,
Points which people have led that we cannot replace the doctors in coming time. We have certain other issues. I had an issue regarding the HIPAA agreement. If you have heard HIPAA Act, it's a Health Insurance Accountability Act in USA, but we don't have in India. In India, the situation, the sociological situation, the cultural and economic situations of the patients are very different from the US of the developed nations. And the data is also certainly different. People, the consent and I think most of the consent for the data in India is not taken from the person. There is no consent at all. A person is not knowing whether his data is being taken or not. That is there. We are talking about MLs and automations and all those things. But down to the line, the situation is that a person needs a good healthcare facility, which an automated machine cannot provide. And second, the data protection bills in India are still pending. The health data, then it's another sensitive point which we need to take care of it. But again, the machine and the poverty and the way the data can be misused is totally a different line. Back in US, we talk about the insurance sector using the pre-existing conditions on medical conditions. The people are being blackmailed on those issues. But in India, the main basic facilities or healthcare facilities, and replacing a doctor is just an impossible thing. People can come on apps, or you can collate data through those apps, but a machine can only provide which is been given to it, or software or the algorithm which has been done to it. And here, I think the data collection has to be more concrete in various ways. I found in HIPAA agreement also, the doctors in US are finding very hard to share their data. They are saying it's really hard because there are two set of people who agree to a data. I want to share my data and what my privacy data. The other is totally orthodox user who doesn't want to share their data. So my question is this, okay, how we gonna put a half-learned machine to a process, because it has to be a very large thing that super AI has been talked about. If it comes to, then only we can rely, because it really relies on our lives which are being into it. Health is more important, being concerned with our lives. So I think the data collection should be basis of with the concerned domestic laws. In India, we are not talking about the domestic laws. First, the law has to be there. And I don't think there is a law, it's just the bill which is pending. And medical care, I don't think so there will be in the future. Recently, we really need to talk about, we are talking about replacing the doctor, but we need to talk about the bill, which is not here actually. So at least in ground reality, we should do something on that. We can see the HIPAA Act, but I don't think so HIPAA Act can work in India. If you people can work on that HIPAA agreement, I think, ma'am, you can say about that HIPAA one, if you can. Can that be in India, if we can have that?
So the question is, can HIPAA be in India?
Huh.
Well, I think that I think it's interesting. I think we can talk offline, but I think that it's not just a question of HIPAA protecting patients. In the U.S., some of the differences are kind of the reimbursement structure, that a lot of the reimbursement is through health insurance, and then there's a whole sort of culture about multiple hospitals and multiple EHR records. And so I think that it's a little bit more complex, but I think that a version of HIPAA could definitely work in India, although it would have to be tailored to the Indian healthcare system, which has some important differences from the US healthcare system. But I'd also like to, we're running a little bit short on time. We have about a minute left. And I know we have one question. Our panelist, Anjali, also has to leave, but I just wanted to make sure that everyone had kind of a chance to speak. So in the 1 minute, if any of the panelists or any of the audience members had anything they wanted to get out there. Yes, sir.
My name is Shukantude. Sorry. My name is Shukantude. I work basically on 5G telecommunication, all the technologies you guys discussed. As I see it, there are I'll take less than a minute, 4 fundamental things in India. Number 1 is the user, the patient. The fact that his or her data is private to her and how valuable it is to her is not known to her. She doesn't know the value of her data. That's a very fundamental thing. And I'm talking about all India. By the way, this is not India. You go to the rural areas, you'll know what India is. It's got so many languages, I won't be able to communicate to them, even though I lived all my life here. Second is the government. The government will always use data for what? For their own purpose, so they remain in the government. That has happened for the last 5,000 years, it'll happen for the next. So the government will use their data. Government has huge budgets in India for healthcare. How is that budget used? Does anyone have any clue about it? And that money is from us, from the taxpayers. Nobody has a clue. I don't know in the US. The third part of the ecosystem is the medical community, which is the doctors, the hospitals, medical insurers, and the whole works. They will use data for their purposes. The data belongs to the patient, the user. And the fourth part of the entire ecosystem is devices. With the Internet of Things and so on and so forth, devices have got interconnected. Huge amounts of data are being generated by each device by human beings in the healthcare system. Do the devices have certain practices, certain standards, interoperable standards, which we have in the telecommunication industry? Obviously, no. So we have got a long way to go, keeping these 4 players in the ecosystem and the understanding that India is a country with 15 languages, 300 dialects. You will always need at the last mile a doctor who is in the same community, same language. So all these AIs and MLs and blockchains, etc., would be enablers. Thank you.
And with that, there's, ma'am, I know you had a comment, so we'll get that in. And
it was actually a question. Am I audible? So essentially, my PhD is in pain physiology, and right now I'm a postdoctoral researcher in the hospital, in public hospital in Sweden. And my research is in psychiatry. So I moved from pain to psychiatry, and basically I look at how people engage in violent aggression, and I look at the neuroscience of it. So there's a lot of research around psychiatry and human aggression. The more kind of sensitive aspects of the data that I look at, I do fMRI, which is functional imaging of the brain, and I do a lot of genotyping. A lot of the problems around that data is you can pick out aspects of criminality, of criminal behavior, antisocial personality, other types of problems that are associated with law and the legal system. And that data is at the moment stored in our systems, but there are companies and industry, and there's private companies in particular, who are interested in genotyping data and that kind of stuff. And I know some of the governments actually sell data because that data has value, and there's a trade aspect of it. Especially sensitive data is not just diabetes. I mean, this is highly sensitive data. And how does that get stored? There's companies that look at ethnicity and where you come from, and that's really fancy, and a lot of people engage in that kind of saliva testing and genotyping, or sequencing, I would rather say, not genotyping. So how does that play into the private industry? And I think Alex might have a few points here, but generally to the panel, because that data is way more sensitive. And how, what are the limitations here in terms of selling, storing, and accessing data of that sort?
And we'll make that our last question, because I know I'm very cognizant about the time. So,
yeah,
Alex?
I'll be sticking around after. I can answer a little bit about the standardized results as well after. I'll speak to you here. So yeah, about genome sequencing, super interesting, because I don't know if you heard of Decode. Decode, they bought about 100,000, kind of not without it being such a direct transaction. They basically bought 100,000 sequenced genomes from Iceland.
There's one in the UK as well. It's another one. Biobank. It's managed by the NHS, but there's other aspects of it. But Biobank is the largest one in the UK.
Yeah. So there's a bunch of them out there, and then obviously in the US we have 23andMe.
That's a private company. Yeah.
Yeah. But there's some interesting kind of things about all of these, right? So just an interesting point is like 23andMe in America, right? It led to a few people being locked up. So a few people that got tested led to a few people being locked up for pretty violent crimes.
See, I work in that specific area, and people who have these particular polymorphisms are not always going to be violent criminals, and that's a huge difference that we've got to make. And I don't know how this is, what
So
was
I
the...
think, both of you are now falling in the line of data security, which is the last point that we touched on.
Right.
Which is, we can talk about confidentiality, standard of care, making care affordable, accessible. These are all good things of it. The vile aspect is this, exactly what you're pointing out, where the security question comes in. And that is why I think all of us should be worried about our data confidentiality, because we don't even know what our data would throw up, which could be a criminal, more propensity for criminal behavior, because that's in my genes what to do. But I would not like to be dealt with that propensity in mind. And I would not like to, the society to be biased against me, because it's bordering on the security aspect, and I think we need another panel for that.
Can I just make one
I think
comment
that
on
we are at the end of time, so
Right.
we can continue this discussion after the panel.
Right.
Thank you to the panelists for their insights and for the audience for their participation and engagement. And we'll be around after the panel. So